Thank you. This is the second time I've got to do this, so I'm excited to be here. All right, as mentioned, yes, my name is Jesse Casaubon. I'm one of the breast cancer surgeons at Baystate. I did my medical school and undergrad in Colorado, and then I did a general surgery residency in New York and breast cancer specific surgical training at Brown and Providence. And I've been here at Baystate for about 3 years now. Okay, I have no financial disclosures. So I primarily work at the Breast and Wellness Center here in Springfield, and we've got a great team of people. This is from kind of the breast surgical side, everybody there. It's mainly providers who are specifically trained to work with patients for a wide range of breast problems. As a surgeon, one of the main problems that I treat is breast cancer. The surgical removal of that breast cancer is kind of what I specialize in. But I don't want you to worry. We see a number of women who come in with problems that aren't cancer and don't ever require any surgery. So I don't want to scare you. I'm just going to put up our contact information while we talk for a bit. I will try to move somewhat quickly through the presentation so we can save time for questions at the end. But other than breast cancer, one of the most common problems that we see patients for over at the Breast and Wellness Center is breast lumps that they can feel, or what we call palpable masses. Palpable just means able to be felt. So some sort of mass that you or your provider, your OBGYN, has discovered. I think most often it's someone who is in the shower and they're, just washing up and they feel something and they say, I haven't felt this before and I don't know if it's normal. And so we do see people for this quite often. And so these palpable masses, what we call them, they come in a lot of different varieties. So I want to begin by just reviewing some basic anatomy so that we'll be able to better classify and discuss these masses, their cause, and what we need to do about them. So this is kind of a conceptualized drawing that we licensed from Therese Winslow of the breast. It's not perfect, but you can see here, especially on this cross section, that if we're looking at the chest, there are the muscles that you know in the ribs and your lungs underneath. And then for the breast, there is these glands. There are these glands that make milk for breastfeeding. They're shown here. They call them lobes. So these lobes produce milk. And then there are these small tubes that basically carry the milk from these milk-making glands down to the nipple. It's not really shown well in this picture, but there are some other supporting tissues that help the milk-making glands and the milk ducts. The first are the blood vessels, which bring all of the oxygen and nutrients through those milk-making glands and those tubes. And then there are also ligaments and just kind of connective tissue that holds everything together to the chest wall. So breast masses, and the reason we're reviewing this, they're often growths that start in one of these four tissue areas. They either start in the milk-making glands, those small tubes called milk ducts that bring the milk to the nipple, or the blood vessels that connect everything, or those ligaments that hold things in place. And so now that we've covered anatomy, we can start talking about the different types of masses. And from there, kind of get started. So masses from each of these structures can form a number of different or can be formed for a number of different reasons, and they can have very different clinical implications. Anywhere on the spectrum from being completely benign with nothing to worry about to breast cancer. And that's my main question when approaching a patient with a new breast mass. And that's kind of the main point of this talk tonight is, how do we know what is and what is not breast cancer when we're feeling something? And the reason we're thinking about this, I mean, yes, it's the area that I have specialized in, but breast cancer is extremely common. So these are the 2018 statistics from the American Cancer Society. So if we look here at women, you can see that breast cancer is the most common cancer in women, non-skin cancer in women. And so 260,000 new cases of breast cancer were diagnosed in 2018. This is just the United States. And this is actually only counting invasive breast cancer. And what that means, most breast cancers start from the milk-making glands, those lobes, or the ducts, the tubes that bring the milk from the gland to the nipple. So ductal carcinoma. And these numbers I mentioned, they only are counting women where the cancer has started inside those tubes or glands and spread out into the breast. This is what we call invasive breast cancer. But there's also about 40,000 cases a year in the United States of an earlier breast cancer that's still stuck inside of those milk ducts or inside of those milk-making glands. And it's important to consider these as well, because we often treat them just like they are invasive breast cancer or the more aggressive or involved breast cancer, because we can catch it early and prevent it. The other thing I want to point out that goes along with breast cancer being so common is that it is, while it's not the number one cause of cancer-related death in women, it's still pretty high with about 40,000 new deaths a year. And what our goal is tonight and for all of what I do is to prevent death from cancer. So here at Baystate, for example, we treat somewhere between 400 and 500 women who are newly diagnosed with breast cancer each year. So it's a pretty prevalent problem. And the most important thing to consider about this, and one of the really good things about breast cancer, if there's any good in it, is that it's one type of cancer that is much easier to treat if it's caught early. And so that's always the priority. You know, if you feel something, we want to know about it so we can figure out yes or no, is it cancer? Because if it is, it's easier to treat. And so I've kind of made a list of all of the things that we're thinking about that go into the treatment of breast cancer, you know, from prevention when someone doesn't have breast cancer to early detection. That's exactly what we're talking about today, finding it early so that it's easier to treat, to surgery, radiation, hormone therapy, chemotherapy, and immunotherapy. And so often when we find it earlier, we can avoid some of these treatments, especially like chemotherapy and immunotherapy. And so I think that's very exciting. We also see people do a lot better when we catch it early. Okay, fine. So how do we do that? How do we catch it early? And what do you need to know about these masses? And what do we want to know? So that's the first thing that happens. Usually you would come in for an evaluation with either us or with your primary care physician or OBGYN, and they're going to ask you questions about this mass. So the first thing that I'm thinking about is, well, how long has it been there? And in that time, has it changed at all? Because a mass that's been present for 30 years and hasn't changed at all in that entire time is much more likely to be benign than a mass that you noticed a few months ago that's just been slowly growing. Growth over time is concerning. We would ask questions about other symptoms as well. We want to know if there is anything else going on, such as discharge from the nipple or changes in the skin. The reason we're asking about changes in the skin specifically, if the skin over the mass is bright red, and you're also having fevers, it's probably more likely that this is an infection than actually some sort of mass growing in the breast. And so that's treated much differently, as you can imagine. We want to know if this is the first area that you felt or if there are multiple areas that you are feeling. For example, this is a key point. it's considered very common and normal for somebody to have nodularity, which is almost like lumpy, bumpy, mass-like areas in the upper outer quadrant of both breasts that comes and goes with menstrual cycles. What that most often is just those milk-making glands, which are very sensitive to hormones, and with each cycle growing and shrinking. One of the things that we see with that is pain, and that's one of the other questions that we'd be asking you about. The next thing that's beyond kind of how this started, when this started, and what else is going on is that we'd want to know about your family history and also your personal history. So, for example, if you are somebody who has multiple family members with breast cancer or other kind of related cancers, such as ovarian cancer, we're going to be much more concerned about something that's happening with you. Same goes for any patient or any person that's had a history of problems with the breast in the past. And so this kind of goes both ways. So for example, if you have developed a benign mass called a fibroadenoma, which grows from that support tissue, that connective tissue, it's often seen that you're going to get more fibroadenomas. So if you're a patient who's had 3 or 4 fibroadenomas removed and they've all been completely benign on the final results, and you pop up with another mass, most likely it's another fibroadenoma. But by the same token, if you're someone who's had some abnormal growths in the breast, maybe there were some atypical cells and now you have a new mass, this is different. This is something that's concerning. Or if you're somebody who has had a personal history of breast cancer, like you underwent treatment for breast cancer a couple of years ago, these are people that we really want to keep a close eye on. And so we're always thinking about what comes next for them, and we're almost never saying, oh, that's okay. And so the next thing that comes after we begin to understand the history of the mass and your personal and family history is that the provider who specializes in breast problems, such as the breast surgeon, or we have a specialized team of nurse practitioners and physician assistants, we're going to perform an exam. We're going to check both breasts and all of the associated lymph nodes, which are like little glands that help drain fluid from the breast, to try and understand the physical characteristics of the mass that you're feeling and discern whether there are any additional issues, such as signs of infection, masses that you weren't feeling, or something like swollen lymph nodes. We're trying to pick up any clues about what this mass could be and help us understand what we need to do next. But the problem is that no matter how many questions we ask and how thorough we are with that physical exam, we can't be sure whether or not it's cancer without at least a few other tests. We rely on 2 basic imaging tests to better show us these masses. The first is an ultrasound. This is a picture of that. An ultrasound doesn't require any radiation. You've probably had one or know someone who has had one in the past. It's where they put the jelly on and then have the little probe that kind of rests right on your skin. So it's very helpful, the ultrasound, for us in looking at masses that people are feeling because of its ability to tell the difference between fluid and solid tissue. And so you can see in this picture on the left here, when it's perfectly black in the middle, that is what fluid looks like on an ultrasound. We can pick up some other characteristics with the ultrasound just to orient you. At the top of the screen, this is the skin, this little layer here that you're seeing from the ultrasound. This is just a little bit of fat. Everybody has just a little bit of fat under the skin that's perfectly normal. And then this band here is breast tissue, those milk-making glands and ducts. And then down here are those muscles of the chest. And so you can see a really, really nice margin around this fluid-filled structure. And so this is what's called a cyst. It just kind of comes from when those milk-making glands are turning themselves over and making new glands. These are completely benign, and we often don't have to do anything about them. Sometimes they'll go away on their own. Sometimes if they're causing a person pain or discomfort because they're big, we can put a small needle in and just drain out that fluid and then not really have to think about it again. And so I want to compare that to this mass that we're seeing on the right. Now, it is also dark, but it's not completely black like the other one. You see this gray in here. And so what this is a solid area. So this is some sort of solid mass. And so the next thing we're looking for is the borders in here. And you see that they're not this nice and smooth, round, cyst that we have on the left. They're irregular. It almost looks like it's growing into the tissue around it. And so this is a breast cancer. And so you can see this difference between a perfectly benign cyst and a cancer. So ultrasound is very, very helpful. The next test that we use often in addition to the ultrasound is called a mammogram. And many people have heard of a mammogram. But kind of to sum it up, it's just a fancy X-ray. It's not a comfortable fancy X-ray, but it gives us a nice picture of the breast for us to see if there's anything going on. It's usually done in these two views. This is a kind of a tough picture to interpret, but this is the right side with the breast compressed vertically, looking, from one side to the other, like straight across. In this picture right here is also the right breast, but it's with the breast compressed horizontally, looking straight down. And then these two pictures on the left are just the left breast. And so you can actually see a little bit. I mean, you do see the nipple. And then all of this white stuff, this is what you might have heard of as being called dense breast tissue. But what this is the milk-making glands of the breast. And so you can see those really well. You can see some of the blood vessels here that we talked about. And that's pretty much it. And so what does an abnormal mammogram look like? So on these two views, you can see that this patient has a mass growing in the right breast. And so this is why the ultrasound and the mammogram are very important. They give us an idea of, what this looks like and what the chances are that it's benign versus malignant. And so it's very, very helpful, but there's still times that we get these two images and we still can't be 100% sure if what we're seeing is completely benign. We talked about the borders and the edges and all of that, but every once in a while we look at something, we say, yeah, well, we just don't really know. We can't be 100% certain. And so in that case, we come back to what I said initially, which is, well, we want to be 100% certain that this isn't cancer because cancer is common. And so what's often recommended at that point is a needle biopsy. This is where the skin is numbed with a little numbing medication and a very small needle. And then a second needle is inserted into the mass and used to take a couple of small pieces of the mass out. I think I have a picture of that. There's a picture of that. This is the needle coming in from the side to take some pieces out of this mass here. Those pieces that come out, they get sent down to the lab for testing. And this is kind of the best way for us to know what's going on anytime we're not 100% certain that it's benign. We perform this procedure very often here at Baystate. And we do strive to make it a really comfortable procedure because we know that anytime you're thinking of a procedure, especially in the breast, it can provoke a lot of anxiety. And so I also, with that, there's anxiety from having the procedure, but I think there's also a lot of anxiety of what the results are going to be. And so I want to talk about our results last year here at Baystate. So here at Baystate, we did last year 10,000 diagnostic images. And so what that means is that's not a screening mammogram. Screening mammograms, the regular old tests that you come in for once a year, they look at both sides and hopefully say that things look good and send you home. A diagnostic is when you say, oh, I have a problem, I'm feeling something. And we examine you and we say, oh yeah, there's a mass there and we want to know what it is. That's a diagnostic imaging. One of the main reasons people end up having these diagnostic imaging are actually when something is seen on the the screening mammogram. So of those 10,000, probably most were from screening mammograms, and maybe 2,000 or 3,000 were for people who came in with masses that they were feeling. But of those 10,000, only 15% or 1,500 were recommended to undergo the needle biopsy. So for most people, we're using these images to say, oh, yep, it looks benign. You don't need anything else. Everything's okay. 15%, though, we say, yeah, there's enough concern that we have that we would like to know. So come back in. We're going to use the small needle and take out some pieces. And so the next question is, okay, well, you did 1,500 biopsies last year. What percentage of those were found to be cancer? And the answer is 390, which may seem like a lot. I said we're seeing a lot of breast cancer at Baystate, but that's less than 1% chance from those initial 10,000 women. So my point, I guess, is that if you're feeling something abnormal, the most likely scenario is that it's not cancer. But it's important for us to talk about these other steps along the way, us talking to you about your history, your family history, the physical exam, the pictures like mammogram and ultrasound, and sometimes a biopsy, just to prove it to ourselves that it's not cancer. Okay, so in summary, I told you I was going to keep this short so we could hit a lot of questions. In summary, though the masses that people are feeling are most often benign, we should evaluate them, or someone should evaluate them, because there's a small risk that they could be something. To help us figure out if they're going to be something, we usually need to see you in the office and then send you for some additional pictures. As I mentioned, occasionally a needle biopsy is done to take a few small pieces from that mass and send it to the lab for evaluation. Having a biopsy doesn't mean you're going to have cancer. Most of the biopsies we do are benign and just help us prove that so we don't have to worry about you. We do know that this is an intense and anxiety-provoking process. But again, I'll mention that breast cancer is much easier to treat when we catch it early. And so that's our goal. We want to work together with you to make sure it's not cancer. If it's cancer, the good news is we know about it. We've done the correct steps to diagnose it, and you're in the right place to treat it. And so that is pretty much all I have. I wanted to share that we are able to do mammograms in a number of different sites, technically 8 locations. We have providers that are seeing patients at, I think, like 4 of these 8: Springfield, Northampton, Longmeadow, Westfield, and Greenfield. We have providers. And so if you would like to get connected for just your regular old screening mammogram, if it's been some time, you can call this 794-2222 number. Or if you're feeling something, it's probably better to have you come and say hello and meet with one of our team members. And so to do that, you can call us at this 794-8899, option 2 for scheduling. And I personally go to Springfield, Northampton, and Greenfield. So we're all over. All right. Hopefully that was helpful.
Thank you, Dr. Casaubon. I would like to, it was a great presentation. I just want to mention that I invite our attendees to type their questions in the Q&A box for Dr. Casaubon, and we'll review all of them. The first question: at what age should I get a screening done?
That is a great question. And so there's a bunch of different answers, and you'll get different answers depending on who you ask. For example, most primary care doctors will adopt the guidelines from the United States Preventative Services Task Force, USPSTF, and they tend to have more lax recommendations for getting screening mammograms. Sometimes they say, well, start at 50 and do it every other year. But what I want you to take away from this is that for basically any type of provider that treats breast cancer regularly, these are the people who are seeing it, and we know how common it is. We almost all recommend starting at age 40 and doing it every year. And so the reason this hasn't caught on with everybody, this starting at 40 and doing it every year, is because the mammograms, if you remember, when we looked at those pictures, the mammograms, it's a little bit more difficult to see. I'm going to flip back, actually. It's a little bit more difficult to see. Like you can see the difference in these two breasts. This is a patient who has more dense breast tissue. And so it's a little bit harder to pick up masses. And the people who have more dense breast tissue are often the younger patients who are premenopausal. They're still having their menstrual cycles. And so those cyclic hormones makes the breasts more active and harder to see through. So it's a little bit harder to pick up breast cancer in a mammogram for someone who's between 40 and 50. And the other thing that goes with it is that breast cancer is less common for people who are younger. It's typically associated with women who are older in their 60s or 70s or 80s. And so someone who's 40 to 50 is less likely to have a breast cancer. However, looking at our own numbers at the Baystate Breast and Wellness Center, a significant portion of our patients, it's like 26% or so, are between 40 and 50. And most of those women had the breast cancer picked up on mammograms. So we're like, yes, you should absolutely do this. The USPSTF, who are the haters of mammograms, they say, well, if we look at financially the system, you have to screen more women to pick up one breast cancer. So it costs more to the system. And I mean, yes, but if you're that person who has their breast cancer detected early and you're, able to save your life, that's what we want. That's the goal. It doesn't matter how much it costs. But so that's kind of the whole controversy. So most of us say start at 40 and do it every year.
Excellent. Thank you. The second question. If you find something, should you go to your doctor or contact a Baystate Health breast surgeon?
That is a great question. And that's a tricky one too, because it somewhat depends on your insurance. Because some insurances will say that you need to have a referral to get in with us. That being said, I would probably start, if you can feel something that's not normal, let's say you started feeling something new and you're like, oh, I haven't felt this before and it seems a little strange. We say, let's check it out. And I think the quickest way to get there, I would call this number 794-8899, option 2. And then if it does end up being an insurance issue, we'll kind of work around that. Sometimes we call people's primary care docs and say, hey, send over referral. So I would say just go for the gold, give us a call. What usually happens is you don't end up seeing a surgeon, which I think is a relief for most people. We have this special team of nurse practitioners and physician's assistants who are just trained to sort out, do we have to be concerned about this? They ask the questions, they do the exam, they look at your family history, they figure out what, do we just need an ultrasound? Do we need a mammogram? And so they're great. And so they kind of sort all this stuff out for us. And, hopefully you never need surgery. We say, okay, we checked it out. Looks good. We can send you home. So I would say, call us.
Excellent. Next question. If you have a sister who has breast cancer, should you get a mammogram annually as opposed to every 3 after age 50?
So it's somewhat another good question. It somewhat depends on how old your sister was when she was diagnosed with the breast cancer. However, if your sister has breast cancer, that certainly means that your risk is probably a little bit higher than the average woman. So I would say do the mammograms every single year, and I would probably start even younger than 50. But it should be mentioned that mammogram is not an easy test. I made it sound easy, like a quick X-ray that's no problem, but it's an uncomfortable test. And, it's a very personal area. And I'm aware of the machines. They do really pull people into the machines to get a good picture. And they do a lot of squeezing. And there is a lot of anxiety, I think, that goes along with it. But, I think the take home is if you can if you can put up with that once a year, mammograms are just excellent at finding cancer and saving lives. And so they've really changed the survival for breast cancer since the 1970s when they started. And if you think about it, in the 70s, they were terrible pictures, with the old, you had to develop them. And now they're so advanced. There's the 3D mammograms, which we have at all of our sites. So they're a lot better at picking up cancer early. So I'd say, if your sister has it or had it, probably good for us to see you. But it does depend, if you've got 10 sisters and only one has it, it's probably a little bit less likely that there's some sort of link between you. But if your sister has it and your mom's mom had it or your mom's sister has it, then we're thinking more about your family as well. So yeah. And our nurse practitioners kind of sort out that risk with you. Well, how concerned should we be by the family history, based on who has what? And so that's one of the questions that comes up, not just breast cancer, but ovarian and uterine and all that. So yeah, good question.
Thank you. Next question. Are women who have had children more apt to have breast cancer than women who have never had children?
So another good question. And this comes back to those milk-making glands and those small tubes, those milk ducts. So I'm glad we did the anatomy at the beginning, but most breast cancers come from the milk-making glands or those tubes that bring the milk down to the nipple. And so a lot of people think, well, I breastfed, or I had multiple children and I was breastfeeding with each of them. So did that cause this? I had a blocked milk duct. So did that cause me to get the cancer from the milk duct? But it's really interesting. It works completely opposite. So the longer that you've breastfed for, or the more pregnancies that you've had, that actually all of those things decrease the risk for breast cancer. So they say that for each year of breastfeeding, for example, the risk for breast cancer decreases by like 3 or 4%. Obviously, you can't breastfeed for 10 years and say, well, I have 0% chance or something. That doesn't exactly work like that. So I don't know how much I trust the percentages. Especially for women who are breastfeeding more than others, but there is some protective benefit to both, having children and also to breastfeeding. Though, to actually look at the statistics, because I get women on the other side who are like, well, I've never had children. How worried should I be? And we typically, it's okay. It's going to be okay. The numbers and the percentage risks, they're pretty small in the long run. So I don't think someone who's not had children should be extra worried. What we care more about, or what we worry more about, is the family history. That's kind of the key. So we're thinking a lot more about the family history than whether or not you've breastfed and if it's 10 months or 20 months, so.
Thank you. Next question. When should a biopsy be done? 2 years ago, I had a mammogram and was called back for an ultrasound. BI-RADS was 3, but TOL's okay. 6 months later, I had another mammogram, BI-RADS of 3. 6 months later, had yearly mammogram, ultrasound, biopsy, and was diagnosed with breast cancer. Wonder if I should have had a biopsy done earlier.
Yeah, that's a great question. And we run into this problem a lot because it's very frustrating when the situation happens, where there's something that you're following and in the beginning it's not changing, and then it ends up being cancer. Luckily, it's not common, but it sounds like, you've been through this. And so the first thing that I think about for someone who's been through this exact scenario is, was the area that they were seeing and following before the area where the cancer was? Because oftentimes I'll dig into this when I'm seeing a new patient with breast cancer, and I'll find that the spot that they were following, even if it's in the same breast, it's like in a different part of the breast. And so it's almost, like, oh, well, it was probably a cyst or something and it went away. But if it's the same area, then yeah, you should have had the biopsy done earlier. Yeah.
Thank you. The attendee was asking about the hereditary question for breast cancer, would like you to repeat the number. And I would imagine that's the number to your office to see the nurse practitioners. And the next question, what if you are unaware of your family history? How do you go about that?
Oh, that's a tough question and a tough situation too. That we do this thing for people that's called genetic testing, and it's a little bit tricky. What genetic testing is it's a blood test. Many people have heard of like the consumer genetic testing, like 23andMe or I forget the other one, but anyway, where you can pay a company to do this. But the real genetic testing that we do is like very, very, very precise. It's similar, the idea. They're going to look at your genes and your DNA, and they're going to identify. We have a list of somewhere between 40 and 100 different genetic problems that could arise that would increase your risk for a number of different cancers. But we would test to see if you have any of these known problems. And one of the genetic problems that many people have heard of is a BRCA or BRCA mutation. There's two versions of this, BRCA1 and BRCA2. And this gained a lot of popularity in the community when Angelina Jolie said, well, I don't have breast cancer, but I have a BRCA2 mutation. I have this genetic predisposition to getting breast cancer. My risk is 80%, somewhere around there. And so because of her risk, she decided to preventatively remove both breasts. So my point in the answer to your question is that it's hard to understand your risk, since you already heard me mention that the family history is really big. So if we don't know your family history, we don't know it. But one of the things that the companies, the real companies that we use to do genetic testing, these companies offer is for people who don't know much about their family history. That usually will help us qualify them for insurance to pay for genetic testing. I will say that that's a little bit tricky. That's kind of like the back door in. Probably you can get someone to pay, we could probably get your insurance company to pay for the genetic test, but who usually orders that is a genetic counselor, and it's hard to get into the genetic counselor just because you don't know your family history. So I've seen some people come through the breast center, but it's also, I think it feels a little bit weird for people to come to the breast center when they don't have any problems. I mean, that's how we like it. But, if you came to the breast center, we could probably try to address that, which sometimes involves genetic testing. But it's not even, it is a tough question because even genetic testing is not perfect. Like, let's say we do your DNA test and it's completely negative. We say, well, that's great. Your risk isn't 80%, but what is it? We're still a little bit in the dark, not knowing the family history. So I think you stumped me on that question.
Thank you, Doctor. We're actually going to cover genetic testing with Allie Richards on Thursday. So you can join us at 6:00 on Thursday for genetic testing for hereditary breast cancer risk. But for the questions tonight, the next one is, if you have dense breasts, can you do anything diet-wise before mammograms to make it more comfortable and clear and avoid ultrasound callback?
That's a tough question. Diet-wise, it's difficult. I don't know if there's something that you could really eat. There are some people who will talk about like the phytoestrogens that are present in soy and stuff like that, and maybe avoiding those beforehand would help. Any sort of food that has any sort of link to estrogen. I don't know if that would really change how things looked. One of the things that helps for pain with women who have, breast pain associated with the hormonal changes and kind of goes along with the dense breasts is this thing called evening primrose oil, which is an over-the-counter supplement. I haven't used it like this yet, but your question makes me wonder if you could have someone take this evening primrose oil, which is, just over the counter, and make it more comfortable. The other question, or the other thing I'm thinking about with avoiding the callbacks, is if you have dense breast tissue, you probably want to make sure that the place you're doing mammograms has the newer 3D mammograms. Most places do, but the 3D mammograms are better able to see through the dense breast tissue and avoid the ultrasound callbacks. So good question.
Thank you. Next question. I'm 45. I've had 5 mammograms, and 3 of those 5 I've had to have needle biopsies, all fibroademas. Am I saying that right? Adenomas?
Fibroadenoma.
Right. Okay. How likely is it I will continue to have a new fibroadenoma every year?
So that's a great, and that I think we even talked about that a little bit today. For whatever reason, the people that get the fibroadenomas tend to like to keep growing them. They're hormone related, as many of the things are in the breast. So it is, I feel what you're asking. It's kind of frustrating to keep having these needle biopsies, and they're all benign. So we will sometimes see patients like you in the office and kind of draw a line at some point, like, listen, we've biopsied 3 of these. We can see them on ultrasound. We can follow them. We can look at the borders. It's probably benign if you've had 3 that are benign already. And so we get to a point where we're like, okay, we don't need to keep biopsying them if they look benign on the ultrasound. But I think the key with that is you probably want to have someone involved with that decision making for you. But yeah, that's an exact situation where we'd want to hopefully save you some of the needle biopsies. And the other answer to your question is that for the most part, after menopause, when the hormones change a little bit, the breasts tend to quiet down. And so I would say probably at the time of menopause, you'll stop getting fibroadenomas, at least is my hope. And that's kind of what we've seen with our patients so far.
Nice. Thank you. Next question. I have dense breasts. Should an ultrasound be used for screening on a regular basis instead of or in addition to a mammogram?
That is a great question. And so it depends on your risk for breast cancer, which we would calculate with like your family history and all those other things that we've talked about, mainly the family history. But also, if you have breastfed and all of that. But the key is for women who have dense breasts and a lower risk for breast cancer, which we just define by the lifetime risk being less than 20%. And so that brings up the next question is, okay, well, what's the average risk for breast cancer? And it's high, it's 12%. So 1 in 8 women in the United States get breast cancer. So we consider low risk to be somewhere around there, anywhere kind of between, 5 and 20. And so for those women, we can use, in addition to the mammogram, you want it to be the 3D mammogram, but in addition to the 3D mammogram, we use ultrasound every 6 months for screening, or you can. The problem is that it's not great at screening. Ultrasound is okay. For about every 1,000 ultrasounds we do, we pick up 2 or 3 cancers when we're doing this screening. So it's possible, and you certainly could. If your risk was higher than 20%, that's where we kind of start to get concerned, like, oh, you're at an elevated risk for breast cancer. So we want to do a test that's better than ultrasound, and that test is an MRI. Many people have had MRI for the breasts. It's extra uncomfortable. It's pretty terrible, but it's excellent at finding breast cancer. Works better than the mammogram, works better than the ultrasound. So we kind of save it for the people who are at a higher risk because it's such a tough test. But yeah, that's the answer to your question. Depending on the risk, you could alternate with ultrasound or something more aggressive like an MRI. Thank you. Yes, 3D. Baystate has 3D.
We see that. Oh, good. Yeah. Just for the attendees, the next question was, do all Baystate locations have the 3D mammograms? And doctor said we do. And looks like this might be the last question. I am 33 and my grandma had breast cancer. Can I get approved to get a screening at my age? It's
going to be a little bit tough for the same 2 reasons that we mentioned. Breast cancer is unlikely in someone who's 33, and the breasts are even more dense at that age. So it's a little tricky. definitely if you had some sort of problem, even if it was like breast pain, we'd say, okay, let's do it. That's easy. So the next thing we'd want to know is like, okay, well, how old was your grandma when she had breast cancer? Because if she was young, maybe we'd be thinking more about you. But with the family history, the thing that kind of gets us to the point of wanting to follow you more closely is what we would call a first degree relative. So, that would be like your mom. So if your mom had breast cancer at 33, we'd say, yeah, let's do it. Or your sister or something like that. First degree relatives are, mother, father, sister, brother, daughter, son. So I think as long as your mom and dad are okay, you probably would start at 40, I would say. Unless you have any sort of problem, then we're going to do it. Let's do it.
Excellent. Thank you. We're just giving everybody another minute if there's any more questions, and I don't see any. Oops, I think one more. Oh, this attendee is saying thank you so much for offering this lecture. Much appreciated.
You're
And
very
I
welcome.
agree. Thank you, Doctor.
Just give us a call. We're here and we're happy to talk about things, even if you don't have problems. It's a little tricky to get in, but if you want to keep working on these things, let's do it.
Thank
and
you,
yeah,
Doctor.
Allie Richards, who's giving that talk on Thursday, she's really good, and her and I work together a lot. And the genetics thing is such a complicated field now that I think I'm actually going to attend that talk myself. So yeah.
Wonderful. Well, thank you for your time and expertise tonight. We appreciate you.
You're welcome. Thanks for having me.